Let's go ahead and get started here. Today we have the pleasure of hearing Alex Isakov talk to us. And Alex is a gentleman that has been very important here in developing the emergency systems throughout Metro Atlanta. He came here in the year 2000 from the University of Pittsburgh, where he got his MD and his MPH from there. And as he came here, he took on the task of trying to set up an effective emergency relief system. CEPAR is the name of the entity that he established, and it was one that kind of oversees all the emergency stuff, looks at all the 9/11 state centers, it looks at all the medical technicians involved in it, looks at the ambulance services, and he kind of coordinates all that and puts it together. It's interesting that he was former U.S. Navy officer, which gave him some background on what he does. He now does consults for the CDC. And as I said, he's very important in the national disaster medical system. And he's been deployed by this group where they land in sites that emergencies are going on, doing that. So as I look at him and read his resume, I'm impressed. He's had oversight responsibility. He's had leadership responsibility. He's been an active participant in some of the big endeavors that have been carrying on. He's been very important in the organization of the medical emergency system. It's important, I think, that we learn and listen to what he has to say today, because as you read about it, the number of people that are getting involved in this is increasing steadily. And that's because the number of people traveling and the elderly people that are traveling is much higher than it used to be. And also the mobility of our chronically ill patients has increased. Where you used to have a chronically ill patient wouldn't dare get on an airplane, and now they're quick to hop on and fly different places. And so this is bringing the exposure to us. I was telling Isaac, first time I had the exposure about a month ago, and so many of you will face this. But we look forward to hearing Alex. As I read his resume, I figured, well, this is our own Indiana Jones here. He's been involved in it. He's been on the scene. He's been very active. And so, Alex, we're glad to have you here and appreciate you coming to talk with us.
Thanks, Doug. It's a real generous introduction. Doug's been a great partner in the time that I've been here at Emory since 2000, as have many of you in the room, in multiple endeavors. Probably in the earliest days of the air ambulance service here that was Emory Flight and is now Air Life Georgia, partnering with various specialty services here at Emory University Hospital and across Emory Healthcare. It's always been important. And thanks, Doug, for acknowledging the CEPAR office, our Office of Critical Event Preparedness and Response, which has a enterprise-wide responsibility to coordinate disaster preparedness and response activities. Today's topic's a little lighter. I'd say by introduction, I'm an emergency medicine physician and I'm an EMS physician. And already there should be quizzical looks in the House of Medicine, like an EMS physician, what's that? So an EMS physician is actually, you can complete now an ACGM accredited fellowship, typically 1 year, and most often after an emergency medicine residency. And what do those physicians do? Well, they get very familiar and immersed in development and oversight of systems of care in the out-of-hospital environment. So everything that happens from the time someone dials 911 to how that call is processed, to how the emergency medical dispatch system is determining who has a medical emergency that is really urgent. It requires, different resources to someone who's less urgent and can maybe have a less emergent response, through working with fire services that typically respond as first responders, and ground services that will transport patients in the 911 system, development of critical care ground transport services, air ambulances, and special event and mass gathering types of medicine, as well as disaster response. In 12 months through didactics and experiential component, you'll finish a 1-year program in emergency medical services. And it's not limited to emergency medicine physicians. That's just where most of them come from. So that's my background. You might be surprised to know that I lead a section now of pre-hospital disaster medicine, have for a number of years in our department. We have about 9 EMS fellowship trained physicians now on the Emory Emergency Medicine faculty, involved in various components of the Metro Atlanta's 911 system. Today, the question you might ask is, well, how does anyone become expert, and putting that in quotation marks, expert enough to make a presentation about responding to medical emergencies in commercial airline, and how did this guy get invited to be in front of you to talk on the subject? And there's any number of answers. I'll tell you the real answer at the end, but any number of answers. So one answer that I've been told is, well, Alex, you look a lot like a flight attendant. You got the short cropped gray hair. You favor a blue jacket typically. So that's one possibility. Two, in emergency medicine, if you've ever walked into the waiting room, I mean, it looks like a lot like the gate at an airport, for a delayed flight. People are sitting there, they're unhappy, they look sick, they're miserable, and they're trying to get inside the plane. In our case, they're trying to get in the emergency department. And much like commercial flights, we have coffee and tea and cookies in the emergency department, stale sandwiches as well. And so there's a lot of similarities and analogs there that you have to consider. The real reason I've been invited to make this presentation, you have to blame Jonathan. He actually, I think he saw that somehow I captured the up-to-date chapter on this topic and thought that would be a good opportunity to put me in front of the Department of Medicine. So that's a lengthy introduction, but I do thank you for inviting me to come. Actually, this was one of the guidance I got in preparing this talk. Tell us something personal about yourself and, give a lighthearted introduction. Today, we're going to talk and just review a little bit about airline medical kits on commercial airliners, some of the medical legal aspects of rendering care on commercial airliners. I know that that's often a point of, concern for physicians that, hear the call. And what the challenges are for delivering that care in this environment. We'll also talk a little bit about flight physiology as it applies to care of patients in the air, and then just some of the challenges about caring for patients in these confined and sort of non-private spaces. And I mean, who here hasn't been on a plane? Who here has not been on a plane where you've heard, if there's a doctor on board, could you please press your call button? Is there anybody that hasn't experienced that? I mean, most of us, I think, have. And so, the other, thing that I can probably go to you for is, well, what is your immediate reaction to that? I mean, I've heard this anecdotally, and, the immediate reaction, I think, for some is, well, let me count to 10 and see if anybody else, hits their button. And what can I do up here anyway? And then probably the last thought is, am I going to make my connection, right? And those are all fair questions. I'd say, another thing that might be, very sort of palpable for EMS-oriented emergency medicine physicians is the impact that bystanders have on patients that are in need of some type of intervention. So this is a little bit, but only a 30-second deviation. Like some of my history is, my father had an at-home cardiac arrest when I was just a dumb college kid. But my mom, who was trained as a nurse, knew well enough to recognize that start CPR until the ambulance could come, defibrillate him, and take him to the hospital where, he had a full recovery and went back to work as an anesthesiologist some 6 weeks later. So, that's one example of, bystanders. Yes, it was at family. 60% of cardiac arrests actually happen at home, but where a bystander made a difference. My brother-in-law's dad, same thing, got dropped off after the Thanksgiving holiday at Hartsfield. And then, his son drove away, and about 2 hours later got a phone call from his dad to learn that he was now in Southern Regional Hospital post-arrest, awake and alert and wondering what in the world he was doing there. And in fact, he had a course V-fib on the AD that was applied by a bystander in the airport. And he came to Emory to get his 5-vessel bypass and still lives today. Another great example of bystander assistance. And I will charge, or I'll posit that you as a physician, especially as an internist or, further subspecialized, you are more capable than anyone else on that plane to render an assessment and some assistance about what happens with that patient, and can in many cases, make the difference between life and death, and in other cases might just make the difference between, the rest of the passengers making their connection or not. But all of that is, something to consider. I would say up front, if there's a take-home message, don't shy away from participating in, the resuscitation or the assessment of someone who's ill on a plane. If it was my mom or dad, if it was my, my daughter or son, I'd hope that it was one of you that was evaluating them if they were having a medical emergency on the plane. So does this happen? It does happen. I mean, there's almost 3 billion passengers flying worldwide annually. And a review of 5 major carriers over a 2-year period showed that there were like almost 12,000 in-flight emergencies. So 1 per every 600 flights. And the most prevalent presentation is for syncope or loss of consciousness, followed by respiratory events, followed by GI. And believe it or not, I mean, nearly half of these flights have some type of physician provider on board. Now, my mother saw that statistic when she was alive, and she said, "When do you work?" You know? And the fact that Dr. Morris said he'd only just experienced this, I think, last month, my immediate reaction to him is, "Doug, you've been working too hard. You know, you need to get on a plane and get on vacation." But over almost half of these flights and responses include a medical provider, and in 7% or so, it results actually in diversion of the plane, you know, to an airport that wasn't its intended destination. What's also interesting about these statistics is these are only the calls that the statistics only capture true medical emergencies. If the flight crew actually manages whatever issue is happening on board without contacting ground support, then it doesn't even get counted. So there's probably even more incidences on planes than there's, you know, being captured by the epidemiology. Whoops. All right, let's see. I'm not going to touch that anymore. All right. So the question then is, if you're going to respond, what kind of resources do you have available to help? And so this goes into the category of stuff, staff, and second opinions. Okay, so let's go with stuff first. What kind of stuff do you have if you go and you respond to a medical emergency on the plane at the request of the crew? Well, actually, what's on board is can vary from airline to airline, but the FAA sets minimum standards. So the minimum standards are that all aircraft are going to have some type of first aid kit. Okay, so Band-Aids and gauze and some splints and maybe some topical antibiotic ointment, first aid kit, that's it. If you have over 100 passengers, you're going to have a 1. If you have over, you know, for every 100 passengers, you'll have another first aid kit. The FAA also mandates that there's an automatic external defibrillator on the aircraft. And we'll talk a little bit more about the effectiveness of AEDs in flight. And then for aircraft that have more than 100 passengers and fly more than 2 hours, they have to have some type of in-flight emergency medical kit. Okay, so that is the minimum that's defined by the FAA. And the question is, well, what's in the kit? So in terms of tools for, you know, assessing the patient, you'll find a BP cuff, you'll find a stethoscope, and they'll also have enough for you to kind of execute standard precautions. So you can find a pair of gloves in there to kind of keep yourself protected from infectious bodily fluids. For airway and breathing, they have an oropharyngeal airway, and they'll have a bag valve mask with 3 different size masks. They'll have a CPR mask with 3 different size masks. The idea is that you should be able to manage adults, peds, probably not newborn sizes, but 3 different sizes of some type of respiratory assist device. You'll find an IV set. I don't know who picks these. If I was picking, I'd be picking like a 20 and 18 gauge at 1 1/4 inches. And you find these 2-inch long, you know, angiocath. They're not my favorite to start IVs in the you know, aisle of an airplane, but you'll find IV sets, and you'll find needles and syringes, and you'll find 500 mLs of normal saline or LR, and that's pretty much it. And in terms of medications, you'll also find them too. Most airlines don't carry narcotics, so you know, if someone's looking for Dilaudid, you're not going to find it in the kit. But you'll find non-narcotic analgesics there. You'll find antihistamine tabs, injectable antihistamines, aspirin, atropine, usually albuterol, MDI, some D50, epi in both 1 in 1,000 and 1 in 10,000 concentrations, IV Lido, and I guess that's probably something that's just left over from, you know, FAA regulations and them slow to pick another, maybe more modern antiarrhythmic, but lidocaine and sublingual nitroglycerin tablets, you'll find, you know, those meds in the kit. Now, having spoken with people anecdotally who have accessed the kit, and you know, I'll speak for myself too, having had the opportunity to respond to a number of medical emergencies on flights, which, Doug, means I'm not working hard enough if I'm having that many opportunities. Finding what you're looking for isn't always the easiest thing either. But don't forget to you know, use the flight attendants. They should be able to help. And actually, if you can't find something that you're looking for, believe it or not, ground support, who puts these bags together, makes recommendations about how they're put together, can help you recently talked to a friend who needed to try and help somebody who was having an anaphylactoid reaction because of an allergy to nuts, and was looking for the epinephrine and couldn't find it, until finally, found some wadded up paper roll or something in the back corner and unloaded it and found the epinephrine. Why they hid it so well, I'm not sure. But sometimes some of these things are hard to find. But don't forget, you have staff and flight attendants to help you. And the flight attendants actually are trained, one, to get you these kits, to get the oxygen, to find the AED and bring it to you if that's what you need. And they're also required to maintain certifications in CPR and application of the AED. So they do know how to do that. So if someone is in need of CPR, while you're thinking and while you're going through the kit trying to find meds, you can ask a flight attendant to help with the CPR. They've all been trained to do that. And then in terms of the second opinion or medical consultation, nearly all the major carriers have some type of ground support consultant that they rely on in real time, even for real-time communications and online medical control. So for Delta, which is our home carrier, Delta gets their medical control or ground support from the University of Pittsburgh's Medical Center. Actually, they've been doing it there since about 1997. We actually tried to break in, but they've had such a good experience between Delta and the University of Pittsburgh. It's impossible to break in at this point. They do a good job. But anybody who's responded to a medical emergency, especially on a Delta flight, knows that the days of actually going to the cockpit and talking to a physician by ground, at least on U.S. carriers, are over since 9/11. Some other international carriers might still allow you up in the cockpit, but U.S. carriers don't allow that anymore. And you're usually doing some kind of secondhand communication from you to the flight attendant to the pilot who's talking to a physician on the ground and then back. And so a lot can be lost in translation, but they are ultimately providing guidance to the pilot about whether or not to divert the plane and what might be appropriate in terms of treatment. So there are some legal considerations when you go to assist a traveler who's having a medical emergency. You actually are establishing a doctor-patient relationship. Another thing to know is that your liability as a healthcare provider is actually determined by the law of the country in which the aircraft is registered. So if you're flying a Delta aircraft or a U.S. carrier, then you are covered by the Aviation Medical Assistance Act, which we'll talk about shortly. If you're flying a Lufthansa, then you're actually you're on a German or European carrier, and it's different. There are differences in your obligation to respond. Actually, for U.S. carriers, there is no obligation for a physician to respond. You should, I hope, feel some moral obligation, maybe some ethical obligation to respond, but there's no legal obligation to respond. For many European carriers, actually, there is a legal obligation for physicians to respond. But if you respond on a U.S. carrier, certainly. Or you are tending to a U.S. citizen, even on a foreign carrier, you are considered, operating under a Good Samaritan Act, or what for the federal, in the federal statute is the Aviation Medical Assistance Act. And what it does is it protects you as a healthcare provider that is responding to in-flight emergencies. So that is one of the premises. It has to be an in-flight emergency. You can't just routinely consult about somebody's cough or provide some guidance about medication regimens. There actually has to be a bona fide in-flight emergency for the Aviation Medical Assistance Act to kick in. And it's effective on domestic flights or international flights involving U.S. residents or U.S. carriers. And it allows for liability in cases only of gross negligence. And that is a really hard bar to get to, gross negligence. That means you are less careless than the least careful, clinician that would be managing a similar situation. But the pitfall, depending on how you like to travel, is alcohol. So a physician or a medical provider who is intoxicated or who has alcohol on board could be considered practicing with gross negligence. So you got to be careful. If you are the type that hates turbulence at 36,000 feet and manages it with 2 double martinis, and then there's a medical emergency, it might be prudent to just sit back and wait for someone else to pull their call button. But here's the kicker that most people are concerned about. What can I receive in terms of gratuity from the airline if they give me a wine basket does that change my liability? If they offer me an upgrade to first class for the remainder of the flight, or for your leg home, is that considered payment? Does it change my liability? And the answer to that is no. Now, so what that means is, after you've cared for the patient, if they invite you to the open seat in business class, take it. That's what I would say. And I've done it myself, and it's quite lovely, in the front of the plane. Now, I say that, the caveat being, if you're looking for legal advice, don't ask a physician, right? If you're looking for legal advice, find an attorney. I'm not an attorney, but most of the literature that looks at the Aviation Medical Assistance Act would interpret it as allowing for you to accept gratuity from the airline without it being considered payment for service, which means you're still being covered under this, Good Samaritan law. Any thoughts or questions on that point? Okay. So rendering care, other good ways to just practice good medicine in the air is, of course, introduce yourself as a physician. You can introduce yourself given, whatever specialty you might practice. Try and find an adequate space to evaluate the patient. In a full flight, that might be very difficult. But there are places to, if you think that the patient is ill enough that they need to be supine, tell the flight attendant, say, this patient, needs to be supine, and that might be an issue of just blood pressure and brain perfusion. And in many cases, they will find what's called a non-revenue passenger that's up front in business class. That means, somebody that's flying on the, who's an airline employee who's flying in business class. They'll move them back and allow the ill traveler to be up front and be supine. Otherwise, you might be in a galley somewhere supine. That's possible too. But the flight attendants can work to find you space. And then there will be communications, obviously, with the flight attendants that you're working with, but then through the pilot with ground-based communications. And so expect that to happen. Ultimately, you're really charged to provide care until the patient's transferred off of the airplane or stabilized. You're trying to protect their privacy as best you can, knowing though it's still a full flight. And then there's every benefit in documenting the care that you render. And in many cases, actually, think about the flight attendant's objective is to, once they've called you into helping with a medical emergency, their objective is to get you to sign the paper, right? But that paper actually gives you the opportunity to chart a history, chart the patient's allergies, chart their medications, put your limited physical exam in, write your impression and assessment and what your plan is, and what recommendations that you made to the flight crew and to the pilot. Take that opportunity to chart all of that. They just want you to sign, but this is a legal record, and it's going to help you if the patient doesn't do well, so that whomever's reviewing that chart or that case can see that your medical decision making was sound, which I know for everyone in this room it would be. And then I guess the secondary benefit is if you spell your name clearly, they'll send you a wine basket or get you an upgrade on the flight home. So there's some flight physiology issues that are worth considering. 2 gas laws. I don't know if I think you all know this, but commercial airlines are pressurized, of course, and they're flying typically 36,000 feet, maybe as high as 40,000 feet. Not enough oxygen at 40,000 feet to sustain, your level of consciousness. It's actually why if you depressurize an aircraft, and I was just reminded of a case from about 2 weeks ago where, the oxygen masks dropped and the plane had to quickly go to 10,000 feet. It's a pretty wild ride. I thankfully have not been, haven't had experience that except in an amusement park. But it's because there's not enough oxygen at 40,000 feet to sustain your level of consciousness. Do you know why, actually, when the oxygen masks come down, they tell you to put it on you first and then assist others around you, like your children, later? The answer is because if you don't do that, you might lose consciousness before you're able to assist anybody around you. So put the oxygen on first if the cabin depressurizes. But even during a routine flight, a commercial airline is not pressurized to 1 absolute total atmosphere. So it is not at sea level. It is not at ambient pressure here in Atlanta, Georgia. It's pressurized to about the equivalent of 8,000 feet altitude. And so that has some physiologic consequences on account of Dalton's law and Boyle's law. So Dalton's law, not to be crazy about gas laws, but basically Dalton's law says that the total pressure of any atmosphere or gas is a sum of the partial pressures of each of the individual gases. And of course, the weight of the atmosphere is what accounts for a concentration of gas molecules, let's say, at sea level. And so when you're at 8,000 feet, actually, the total ambient pressure is less. Oxygen percentages stay the same. It's still 21% O2 at 8,000 feet, or at 10,000 or 15,000 feet, but there's far fewer oxygen molecules. There's far less total ambient pressure. So if the partial pressure of oxygen at sea level is 160 torr out of a total 760, right, which is one absolute total atmosphere, that's 21%, of course. At 8,000 feet, total absolute atmosphere, or the total ambient pressure at 8,000 feet is about 565 torr. 21% of that's 118 millimeters mercury ppO2. And so the number of oxygen molecules is that much less. The PaO2 at altitude is about 60 versus 75 to 100. And that's kind of equivalent to breathing a 16% oxygen mixture at sea level. So for anyone that may have some level of O2 dependence, it could compromise them. So patients with severe coronary artery disease, certainly patients with COPD, maybe with an asthma exacerbation, maybe with pulmonary fibrosis, anyone that is sort of on the edge of oxygenating, well, in that flat portion of the pulse oximetry curve, at altitude actually could drop off and get symptomatic. And so that's something to consider, and it's in part why airlines are carrying supplemental oxygen, is that they know the ppO2 at altitude is less. Boyle's law, you may remember, is that the volume of the gas is dependent or inversely proportional to the ambient pressure. And so what that means is at 8,000 feet altitude, the volume of gas increases about 35%. So in closed spaces, that can be significant. I mean, it is why, if you had the chili dog prior to getting on the plane, that you might feel some increased discomfort, when you get to altitude. Also, if you have a URI or you have a sinusitis and you have trapped gas in your sinuses, that gas is trying to expand when you go to altitude, and it's miserably uncomfortable. That can also happen for people with dental disease, having air near the apices of their teeth. This odontalgia can be absolutely miserable, and there's really very little that you can do to relieve it, except over time, over several minutes, it starts to dissipate. But it also impacts any other gas-filled medical device. So pneumatic splints maybe are the most the one I would probably raise most attention to. If the pneumatic splint for a fracture is comfortable at sea level or in the airport, it may get increasingly uncomfortable at altitude. Any air-filled cuffs of any kind, whether they're feeding tubes or Foleys and whatnot, can be impacted. And some insulin pumps have actually been shown, because of air bubbles in the system, to deliver more insulin than is regulated as a consequence. And so those are just things to be aware of with regards to gas expansion at altitude. So what kind of patients' conditions are we seeing in the air? Cardiac arrest, it's only 0.3% of all emergencies, but there's a high mortality rate, 86%. Of course, you can imagine the challenges of managing a cardiac arrest in the air. You do have some resources, and the AED is very valuable. Of course, the flight attendants are going to bring you that emergency medical kit. Don't forget that you have oxygen on board, and that also the flight attendants can help you with CPR. And if you do get return of spontaneous circulation, ROSC, then there's no doubt that your recommendation, of course, to the crew is going to be, hey, you need to divert this flight and get this patient, off the aircraft so they can go on to get further care. It's also possible that you're over the Atlantic or Pacific Ocean, and you're going to be nowhere near land for several hours. And somebody goes into full arrest, you apply the AED, no shocks advised. You start CPR, you get into the emergency medical kit, you find the epinephrine, you start a line, you give a milligram of epi-IV, and you continue CPR, and there's still no shock advised, and there you are doing CPR. For how long is the question? And international guidelines say that if you don't get ROSC for approximately 30 minutes, so no return to spontaneous circulation after 30 minutes of continuous CPR and no shock advised on the AED, that is a reasonable benchmark for stopping resuscitation efforts. Now, there's an interesting case report actually of someone who shocks were advised and the AED was applied, and the patient received 20 defibrillatory shocks in the time that it took for the plane to divert to ground. Most aircraft from altitude, the least amount of time it would take to actually get on the ground is going to be 20 minutes. But anyway, I think this is a good rule if you find yourself on a transoceanic flight with somebody in full arrest that isn't responding to any interventions, and and morally and ethically, and given what guidance there is, how long you need to continue the resuscitation effort. Outcomes in VFib arrest in the air. I mean, there's not a tremendous amount of data, but it's interesting. They did a 2-year assessment of AED applications on patients that were in the air. So there were 200 AED applications. Now, it's interesting. I don't know the details of why, but only 100 or so of those were documented loss of consciousness. So maybe the AEDs were applied, just precautionary, or I, again, don't know the circumstances. But what is interesting is that of the 14 ventricular fibrillation events that were captured in those arrests by the AED, 13 were defibrillated to ROSC on the first shock, and the survival to hospital discharge was 40%. That's pretty good. And it approximates outcomes in cities, out of hospital cardiac arrest outcomes in cities that are doing a good job at resuscitating their out of hospital cardiac arrest survival. Now, for those of you who know AED literature at all, you might say, wow, that is a really low number of initial rhythms being shockable. So if you look at AED, if you look at the literature on AEDs and initial rhythm, community-wide, the most prominent rhythm that's captured on an AED is actually VFib, and maybe 70%. And in the air, it's only about 25%. And nobody really knows why, but the thinking is that for those that are having AEDs applied in the general community, it's because they've been a witnessed arrest, and so the event is recognized early. But for somebody on a plane who goes into arrest, it may be that people mistake them for having just dozed off or sleeping or something else, and so recognition of the event's delayed, and that may be the answer for why VFib isn't captured as often in the air as it is in just general AED use in the community. But 40% for those that are defibrillated and get ROSC in the air, which was pretty good in a small number of patients. Acute coronary syndrome, also possible, so chest pain, shortness of breath. Again, the thing you might be wondering, what am I going to do with this ACS patient in the air? Well, you have oxygen, which is critically important. Remember, we talked about Dalton's law and then the relatively low PPO2. You can give him an aspirin. There is sublingual nitro on board. I think, of course, we all know that we have to guard against giving sublingual nitro to a patient that might be having an inferior myocardial infarction. You only have 500 mLs of normal saline in the aircraft, so you're not going to be able to volume resuscitate them very aggressively with what you have available. But there is some fluid. But that's what's available to you. And then the question is, do you recommend diversion? I mean, I think as a physician managing someone who you think has active acute coronary syndrome, you're going to recommend diversion to the flight crew and to the pilot. But ultimately, the decision is the pilot's. So you're going to document that you made that recommendation, but the pilot has more information with which he's making a decision, like the fact that, well, there is no aircraft that can land my Airbus 380 for 4 hours distant, and so that may be why they're not landing. Actually, between cardiac arrest and acute coronary syndrome, it is the #1 cause for aircraft diversion. Dyspnea, 12% of all air medical emergencies. And some of what might be precipitating COPD and asthma exacerbations is that the relative humidity in a commercial airliner is really low, like maybe 20% relative humidity as compared to 70 or 80%. And so reactive airways disease might be aggravated by the dry air. There is, again, oxygen on board to help, and MDIs, although I haven't seen a spacer in one of those kits to help deliver the nebulized beta agonist, not the nebulized beta agonist. The patients that have at baseline less than 92% pulse oximetry, are advised to fly with supplemental O2. Neuro conditions, we'll also see occur in 2% of flights, suspected strokes. Space is limited, of course, equipment's limited, and what you won't find is a glucometer. So, and again, I don't know why. It's probably a quality control issue and trying to make sure that the glucometers are, meeting quality control guidelines. But most aircraft don't have a glucometer on board. That doesn't mean that you can't ask other passengers for one. So, in patients that are having some altered mental status or even signs of stroke, having an ability to check a glucose would be very valuable. Of course, absent that, you could give, dextrose, although we know there's some peril with that in ischemic stroke patients. But don't be shy about asking for a glucometer from among patients on the, travelers on the flight. You might be able to get it. In terms of seizure management, I mean, most of these, seizures are self-limiting, of course. Most aircraft, the FAA certainly doesn't require commercial carriers have IV benzodiazepines, but it's been reported that if you could get either Valium or Ativan tablets, that you can actually crush them up and administer them as a suppository. You're probably going over and above the call. Remember, there is a kit for universal precautions on the aircraft if you choose to go that route. I mean, it's something to consider. I don't know if I would have come to that, without having read it in a journal article. For someone in status epilepticus, it'd be reasonable to consider that as an option. Your options are going to be fairly limited. Allergic reactions, I mean, there's just an increasing incidence, at least anecdotally, among just the population and their allergies to various nuts. In the aircraft, you have oral Benadryl, you'll have IM Benadryl, and if needed, you have IM epinephrine. I guess if you had true anaphylaxis that was requiring IV epinephrine, you could find it there. You'll have 1 milligram, 1 to 10,000 dilution. And if you find yourself in a situation where you're really, managing an anaphylactic shock patient, and you'll only have that 1 milligram of IV epi, you'll have the 1 milligram of 1 to 1,000 that the airline kit provides. And then, depending on how sick the patient is and how long you have to fly until you get to your destination, you might be looking for other, epi auto injectors from among passengers on the aircraft. So that's another thing to think about. Remember that the passengers on the aircraft could be a big help to you too in terms of resources. Regarding communicable diseases, this is another consideration. Again, there's a kit for you to implement at least standard precautions in the aircraft. And so if you suspect somebody has a fever, let's say rash, fever, GI illness, and you're on the same flight, you might, if it's possible, consider trying to isolate that passenger from other passengers on the aircraft. If there's a surgical mask and they're coughing, you might, and there should be a surgical mask on the plane. You might, if the passenger patient tolerates it, apply that surgical mask on the patient so that decreasing their likelihood of spreading droplets. And if for any reason, I think it's reasonable for you to underscore for the crew, hey, this patient has a fever and a cough, and we're flying back from Saudi Arabia. You might want to alert the public health authorities where we're landing that we have somebody with an acute febrile respiratory illness, and you may not know their entire travel history, but it could be of interest to the public health authorities when they land. There have been case reports of tuberculosis, influenza, measles, and novel coronavirus suspected as having been transmitted on an airplane. I think for TB guidance, at least the paradigm is that it's a flight of 8 hours or greater duration and within 2 rows of the patient that public health really takes the greatest interest in. Bruce, I see you're in the audience. I don't know if there's been any change in that guidance. So there's always shades of gray, right? Okay, with regards to diversion, we've already talked about this before. Based on the patient's condition, sometimes that decision is going to be obvious. So a patient in cardiac arrest that actually gets ROSC with the AED, that patient needs to get off the airplane as soon as possible, get to probably a PCI capable hospital to get assessed and further managed. Chances are that if you're in that scenario that we talked about before, where you've been doing CPR for 30 minutes, there's never been a shock indicated, they haven't responded to any pharmacologic intervention, and you decide that after 30, 40 minutes of CPR, you're going to just call it. Chances are, well, not chances are, almost certainly they are not going to divert the flight then for someone that you determine is deceased, and they will just find a place for that deceased passenger to rest until they get to the destination that they intend. In some cases, it's a judgment call. I can think of, the scenario I think I was sharing with Jonathan was the time I did recommend a flight be diverted was for a GI bleeder that presented herself several hours after departing Atlanta, heading to Amsterdam. And before we got off the North American continent, she had a syncopal episode and looked pretty pale and diaphoretic, and then felt better to go to the bathroom and dump a lot of melanotic stool and look more pale and diaphoretic, at which point I started a line and gave her some fluid, and she kind of stabilized. And the pilot said, well, what do you think we should, or the crew asked, what do you think we should do? And I said, I think you should get her off the plane, because the 500 mLs that I gave her is all I've got. And if she crashes now, there's nothing I can do. And they did land the plane very quickly. The decision, though, is not yours as a physician. Your role is to make the recommendation. So you can recommend that the patient, or that the plane divert to get the patient off the plane. I can think of scenarios. I mean, here's, if you want to get more gray zone, think about, epigastric pain in somebody with diabetes, and whether or not acute coronary syndrome is on your differential. You might recommend that the patient, that the plane divert. You might say, listen, I can't rule out that this patient isn't having an NSTEMI or even a STEMI. You should get them off the plane. And if ground support says, why don't you give her some Mylanta and see how she does, and her pain goes away, they may very well say, just go on to the final destination. It's their decision ultimately. All you can do is document what you recommended. And that's what I would do. Diversion costs air carriers money. Why? Well, because they dump a lot of fuel. If they're earlier in their flight, they can't land heavy, so they dump fuel. Or they're going to have a lot of passengers that now have to get on, that have missed connections that they have to make accommodations for. Baggage, gets redirected, misdirected, and whatnot. So estimates for how much it costs an air carrier I've seen anywhere from $50,000 to $100,000 on a diversion. So, I mean, that's obviously in their calculus somewhere. But at least in the cases where I've been involved, I haven't been party to a pilot's decision that wasn't in concert with what I had recommended in any case. So the summary points, and I'd say we're probably in good time here. As kind of reiterating the point that I made in the beginning. As a trained physician, you're the most qualified person to go and render an assessment and to provide some intervention. And like I said, if it was one of my family members who was in trouble at 36,000 feet, I would be grateful if you came to assist them, and if nothing else, provide some reassurance that it's not truly a medical emergency, or find some solution if it is. Medical supplies are limited, but they're not absent. We talked about what is on the plane, and the list that I gave you is the FAA minimum. As an example, Delta started carrying naloxone now on their aircraft, and depending on the carrier, they may have more in their emergency medical kit than what I've described. So, and there's usually an inventory list in the bag or in the kit. So, if you're faced with a medical emergency that you think is going to benefit from some type of pharmacologic intervention, ask for the emergency medical kit. Take the time to open it up and look through it and see what they have. It may be more than what I've described. The flight crew and the passengers are a resource. Like I said, flight crew knows CPR. They can assist with that. They're the ones that are going to be talking with the pilot that is in communication with ground control. Things that often aren't carried, like auto injectors of epi, like an EpiPen or a glucometer, might not be in the emergency medical kit, but it might be in the carry-on baggage of a passenger, and so that is a resource. Consider your flight physiology. It's sometimes easy to forget to supplement O's in a patient that's complaining of some chest discomfort or looks a little bit altered. And so remember, the flight physiology is a factor, and supplemental oxygen is available. Liability protections are afforded. Enjoy your upgrade. Take the wine basket. If you're still managing the patient, hold off on enjoying that glass of wine probably until after you've transferred care, to some EMS agency if they've diverted, or there's an EMS agency waiting when the plane lands. But accept the gratuity. You deserve it, and ultimately enjoy your flight. Thanks so much for inviting me to join you guys today. It's a pleasure. If there's any questions, I'm happy to try and answer them. Or if you have an anecdote in particular you want to share. Dr. Kraft, is that you? Yeah, sure.
Oh, sorry. All right, just wondering if there's an ACLS like cheat sheet on the flight with my atropine and my epinephrine.
Yeah, that's a great question. And to be honest with you, I don't recall if there's a cheat sheet. And maybe that's because I haven't had the occasion to look for one. But it's certainly, it's certainly a reasonable thing. I'll tell you, any of the pocket guides that we now have on our, smartphones are kind of a nice resource to have too, in case you need it. Yeah, good question, Colleen. I don't know if they have them in the kit. Yes, ma'am.
So why don't we have EpiPens on the flights? Is it because they're expensive and they have expiration dates, or it seems like that would be a given?
If you were asking me, that's what I would say. It's the expense. So they have vials of epi. You can draw up, the 1 milligram of 1 to 1,000 epinephrine and administer it. It's certainly cheaper, right, to put a vial in the kit than it is to have an EpiPen. John, you may have a better answer for that. I think it's cost.
That was terrific, Alex.
And last point, even EMS agencies. Even EMS agencies with EMTs or advanced EMTs, so not paramedics. Paramedics are trained to draw up epinephrine and administer it. Paramedics are the only pre-hospital providers, in the EMS world that are trained to draw up epinephrine and administer it. Advanced EMTs can assist with an EpiPen if a patient has one, but they're actually trying to make provisions for advanced EMTs to draw up epi because the auto injectors are so expensive. They don't want to put them on like advanced EMT ambulances either. John.
That was great, Alex. Thank you very much. Question, having had one experience like this myself, the stethoscope is extremely hard to use because my ears pop after about the first 15 seconds that we're going up. Sure. So the questions about palpable blood pressures, palpation was pretty much how I managed. Is there something to know about relying completely on palpated pressures as opposed to ones that you auscultate?
No, I don't think so. I think it's, at least in my view, unless someone else has some input on it. One, I'll agree, the ambient noise in the aircraft is elevated. It may be hard to hear with a stethoscope, and they're not putting a cardio 2 on these aircraft. They're putting the cheapest crappy stethoscope that you can buy, in these kits. But in terms of the benefit of a palpable blood pressure, I can tell you on an initial assessment, and I've assessed patients that were unconscious, and in every case they were unconscious because they took for the first time over the Atlantic, some benzodiazepine or trazodone that wasn't prescribed for them in double a dose than was prescribed for the patient, and found themselves, somnolent and unarousable. And in every case, the fact that they had palpable radials, I still, make equivalent to a systolic, pressure of 90. I still use, femoral pulses if the radials are absent to say, okay, I feel comfortable. I have some systolic BP, but a palpable, cuff pressure, I think I think it's reasonable, at least to get you a systolic and give you an idea about what you're dealing with. And then the other thing that in managing some of those, I was able, through vigorous sternal rubs, I know horrified some of the passengers, to get those patients to actually open their eyes and look around and, be awake while still upright. But had that not worked, I would have, on the issue of perfusing your brain, would have told the flight crew, listen, you need to help me get this patient supine somewhere, whether it's right here in the aisle or in the back of the galley or up in, business class.
Question from Grady. Is there any literature or guidance about psychiatric emergencies?
Ooh. There is limited guidance. So you will find yourself, called to the agitated passenger too. And maybe, even violent passenger. I think a lot of, how we assess those patients even on the floors or in the emergency department, have to be considered too. So is the agitated patient agitated because they're a psych emergency, or are they agitated because they're hypoxic? Are they agitated because they're hypoglycemic? Those are important questions to sort through initially, and trying to administer supplemental O2 or determine their blood glucose level could help. In terms of when I think about the medications that I described as in the standard emergency medical kit, the only drug that would have some sedative property would be that IM Benadryl, right? There's no benzos in most cases. And I think it would be hard. I can consider cases where you're having some anticholinergic signs with a patient who's now delirious, and now you're only aggravating that with some IM Benadryl, but that's going to be far fewer cases than not. The only thing that I reference a case in the chapter that I write in Up to Date is they do caution about sedating or overly sedating agitated patients. There was at least there's one report of a patient who died as a consequence of probably in part maybe whatever the underlying issue was that caused their agitation, with then the addition of sedation and the inability to properly monitor that patient. And so there was some litigation that followed. Beyond that, I'm not aware of any other specific guidance for the psychiatric or behavioral health patient. Yes? I think it's, so thank you for asking that question. And in our, implicitly biased world, as a female physician, you're going to fall victim to that anecdotally, not that I have any literature, more so than your male counterparts, regrettably. And I'll tell you a story from a friend's history. She was an internist at Mayo in Rochester, who, when the call for a physician was requested, she hit her call button, and she saw that the patient was slumped over in the chair just a few rows forward, and she went to assist. And the flight attendant said, "Ma'am, no, we're only looking for doctors." And she said, "Well, I am a doctor." No, a physician. We're looking for a physician. No, I am a physician. I'm on staff at Mayo in Rochester. Would you like to see my medical license? I think she carried, I do too. I carry a medical pocket, like, my Georgia license in my wallet. And the flight attendant's response was, "Yes, that would be great. Could you show me your credentials?" I've never, ever been asked, for credentials as a graying male, physician, ever. And so I think there's some bias there, and unfortunately, we're still living in that biased world today. They just don't recognize the female who wants to respond as a qualified physician. So I don't think there's any need. Actually, so to answer your question technically, though, if the airline is the one that is responsible for making the assessment that you are a qualified responder, right? And so if they challenge you for credentials, they could. Now, it's up to them to decide whether they're going to challenge you for the credentials, or if they didn't, what the consequences might be. But they are charged to ensure that if you're responding as a medical provider, that, like, if anyone's accountable for that aside from you personally, they are for letting you assist the passenger.
Are you responsible for any documentation? You listed documentation. Are you responsible for turning in any documentation?
So the best practice is that you document what you've done, and the airlines do have a form that allow you to document that. And there's only been one case where I've responded to a medical emergency where their airline failed to produce the document. And I think this was a case where I responded, as did like a CRNA from another part of the plane, and we worked to try and wake this guy up that took 200 milligrams of trazodone for the first time in his life, right? And I think in the end, I don't know what I was doing, but I think they grabbed the CRNA and said, "Hey, sign this form." And she did, and then I never saw the form again, but I actually asked for it back because I was primarily, I was primarily assaulting this gentleman, trying to wake him up, and I wanted to document what I had seen and the fact that I had elicited this history of a 200 milligram trazodone ingestion, and that, you know, kept an eye on him through the flight to make sure he continued to breathe and whatnot. So I requested that they bring the form back to me, and they did.
So there's one recent event that I was in. At a recent event that I was with, is a person had seizures, and there was nothing to protect their tongue, no tongue blade in the airplane, which I was surprised.
Another question from Grady. If you're the only one on the flight and you still had a glass of wine, should you respond?
You know, the best way to answer that question is you should consult with your attorney. You know, that's the only good way to answer the question.
Any other questions? Alex, we certainly appreciate it.
Thanks, Doug. Thank you very much. Appreciate it.